Dear colleagues, it is a great pleasure to announce the release of the new guidelines for the treatment of dyslipidemias, a joint effort between the European Atherosclerosis Society and the European Society of Cardiology. There are a number of new things in these guidelines that capture all the new information we have gathered since 2016, where the old guidelines were released. And mainly what we focus is in a new way of stratifying risk with new tables, and you will see in a minute. There are other data to be presented that have been collected, as I mentioned, in the last few years. And then a new section on some factors like LDL-C and inflammation. I will introduce in general the guidelines. The colleagues who will follow me will get more deeper into specific points. So what are the new recommendations? Well, we went along the lines that have been established in the previous guidelines by reiterating the central role for LDL as a causal factor in atherosclerosis, but at the same time we took on board the most recent observations related to the lower levels of LDL and the increased risk. So we tried to suggest a further stratification that follows the original guidelines that said more intensity with more risk, but we propose some more intensive goals for the very high risk population. In addition to that, we also consider the possibility of the extreme risk population, which will suggest for a goal that is lower than the previous ones, indeed 55 milligrams per deciliter. Still, the concept of percent reduction remains, and this is to ensure that everyone, independent of the starting point, non-treated LDL, will get a benefit of at least 1 millimole reduction. There are also other points that have been stressed as usual with our guidelines, and those go to special population. Major emphasis has been put, of course, on the familial hypercholesterolaemia as an example of how lipids can damage your arteries. We also have touched upon the definition of the adverse effect of statins, trying to reconcile the differences between what you observe in everyday practice and the data from the randomized clinical trials. So the word statin intolerance, statin adverse effects have been recapitulated in the guidelines, and we propose newer approaches. And we really try to encourage the use of the maximum possible dose of a statin. We also addressed new outcomes trials with PCSK9 inhibitors, putting them in the right perspective and recognizing the benefit of a further reduction of LDL, provided that the risk is very high. And finally, just a short mention about cost effectiveness. This is not our main purpose, but we have to recognize that there are drugs that are generic, less expensive than used to be, and those have to be the starting point, also because of the plethora of data that have been collected. So going back to the novelties, also the scoring system has been revised, and the score system now extended to older people. So we go up now to 70 years of age. You will appreciate that, and that will solve, at least in part, some of the issue we have had with a relatively younger population. Of course, you will see that in primary prevention, the 10-year risk is going to be very high as you grow older. Then there are some key messages for the risk estimation to the population that needs to be treated and the population that needs to be considered for risk estimation. And we have several indications that the risk estimations are all not fully precise. So we have to consider that, and we also have to consider there may be other factors that contribute risk that are not considered in those charts or algorithms that are available. To make a long story short, here are the definitions of the very high risk. And the very high risk has been somehow restructured with people with documented atherosclerotic cardiovascular disease either clinical or unequivocal on imaging. Documented include acute coronary syndrome, myocardial infarction or unstable angina, stable angina, revascularization of the coronaries, stroke, TIA, and also peripheral vascular disease. This is very important. Was already there in the previous guidelines, but as you know, evidence has been gathered that this population has a very high risk of subsequent events. Then for diabetes mellitus, people with diabetes are considered, but we consider those only with organ damage to be at a very high risk. And then people with severe CKD with below 30 milliliter per minute clearance for eGFR. Finally, a calculated score about 10 for a 10-year risk of fatal cardiovascular disease. Please understand that a fatal risk of 10 means roughly 30 to 40 for total cardiovascular events. And then people with FH and cardiovascular disease, or with another major risk factor, such as diabetes or increased blood pressure. The other risk follows, and they go along the lines we have established. You may well remember this core table of the previous guidelines. The structure has not changed, but has been somehow modified to divide between primary prevention and secondary prevention. And secondary prevention, all the people is a very high risk population. And as you can see here, when you cross the risk with the levels of LDL, you see that now the red part covers up to a level of LDL that is between 55 and 70 milligrams per deciliter for the secondary prevention, while for the primary prevention, still that sets to the stage between 70 and 100 milligrams per deciliter, that is 1.8 millimoles to 2.6. Here we suggest immediate intervention together with lifestyle changes. But the general spectrum has not changed, only the goals have been slightly modified. And then what are the targets? Well, the target is the LDL, as I said, and the goals have been changed and made more intensive according to the risk. For the very high risk people, a 50% reduction is suggested, and an LDL goal of below 55 milligram per deciliter. Then a recommendation for the lowering of LDL, we have set the stage for a consequential approach, and the consequential approach essentially goes with starting at the first site as a pillar of the therapy, followed by ezetimibe or combination starting right away in some instances, and then you may consider other approaches such as PCSK9 inhibition, provided that the risk and the level of LDL are such that require this approach. Then we keep also some other suggestions there for cases of statin intolerance and for cases where you may need some other drugs, including salt absorber inhibitors. So in conclusion, this is the general overview of the guidelines. There are novelties. It's not a revolution, but it's more sharp and more intense to the concept that the risk is driving the intensity of the therapy. Of course, the risk is driving the intensity of the therapy needs to have an LDL high enough to support the reduction. And this is also the other point we have. We have crossed LDL with risk, and higher the risk, lower the LDL you will be requested to achieve to obtain the maximum possible benefit in terms of reduction of atherosclerotic cardiovascular events.
I will be summarizing the approach to the high-risk and very high-risk patients in the new dyslipidemia guidelines. The risk categories are similar to the previous guidelines. For very high risk, we have patients with documented atherosclerotic vascular disease, those with severe chronic kidney disease, a calculated score risk of more than 10%. There has been a slight change, diabetes with target organ damage, and in addition, more than 3 major risk factors or early onset type 1 diabetes of duration more than 20 years is now considered very high risk. Also, familial hypercholesterolemia with atherosclerosis or with another major risk factor is also very high risk. As for high risk, it's quite similar to the previous guidelines. Patients with markedly elevated risk factor or familial hypercholesterolemia without other major risk factor, moderate chronic kidney disease, and a calculated score of 5 to 10% is high risk. In addition, patients with diabetes without target organ damage, with diabetes duration of more than 10 years or additional risk factor is high risk. And in moderate risk, we have young patients with diabetes duration less than 10 years without other risk factors and a calculated score of 1 to 5%. The remaining are considered low risk. The recommendations for treatment goals for LDL cholesterol has changed significantly in the new dyslipidemia guideline. For patients with very high risk, an LDL cholesterol reduction of at least 50% from baseline and an LDL goal less than 1.4 millimole or 55 milligrams per deciliter is recommended. This is a class 1 recommendation. Also, for patients with atherosclerosis who experience a second vascular event within 2 years, an LDL cholesterol goal is optionally less than 1 millimole, which is 40 milligrams per deciliter, and this is a class 2B optional recommendation. For patients with high risk, an LDL reduction of at least 50% from baseline and a goal of less than 1.8 millimole per liter or 70 milligrams per deciliter is recommended. So as you can see here, as the patient's risk goes up, we need to go down to lower LDL cholesterol levels, and you see the treatment goals for LDL across categories of total cardiovascular risk. The intervention strategies are decided as a function of total risk and LDL cholesterol levels. And as you can see here in this slide, this table is slightly changed from the previous one because even if the patient's risk is not too high, if the LDL is above 4.9 millimole per liter or 190 milligrams per deciliter, then concomitant drug together with lifestyle is recommended. As for drug treatment, it is recommended to prescribe a high-intensity statin up to the highest tolerated dose to reach the goal, and if the goals are not achieved with a maximum tolerated dose of statin, combination with ezetimibe is recommended. These are class 1 recommendations. For secondary prevention patients at very high risk, not at their goal, both with statin and ezetimibe, combination with a PCSK9 inhibitor is recommended. This goes for very high-risk FH patients as well. So, expected clinical benefit of LDL-lowering therapies is summarized in this table. With a moderate to high-dose statin, you can get a 30 to 50% reduction. If you add ezetimibe, it will be approximately 65% reduction, and an addition of PCSK9 inhibitor can get you an 85% reduction of LDL cholesterol. There are also recommendations for therapy in very high-risk patients with acute coronary syndromes. In all acute coronary syndrome patients without any contraindication or definite history of intolerance, it's recommended to initiate or continue high-dose statin as early as possible, regardless of the initial LDL cholesterol levels. This is a class 1 indication. Lipid levels should be re-evaluated 4 to 6 weeks after the ACAs to see whether we're at goal, and if not, then ezetimibe may be added to treatment. And after 4 to 6 weeks of double treatment, if the patient is not at goal, then a PCSK9 inhibitor may be added. Also, for patients undergoing percutaneous coronary intervention, there is a Class 2A recommendation of routine pretreatment or loading with high-dose statin. It should be considered as a Class 2A recommendation.
Welcome to EAS and the presentation of the 2019 EAS Guidelines for the management of dyslipidemias and lipid modifications in cardiovascular prevention. My name is Olov Wiklund and I am Professor Emeritus at the Wallenberg Laboratory at the Sahlgrenska Hospital in Gothenburg, Sweden. These guidelines were presented this year at the ESC Congress in Paris, and I have been a member of the task force for the development of these guidelines. My task today is not to go through the whole guidelines, but to focus on a special aspect of the guideline, and this is the management of dyslipidemias in different clinical settings. In the guidelines, a detailed analysis and guidelines are given for treatment of various different clinical settings, such as familial dyslipidemia, women, older people, diabetes, patients with acute coronary syndrome, stroke, chronic kidney disease, and transplantation. I will focus on two of these clinical settings that are common and are associated with a remarkable cardiovascular risk and are also treatable. Familial hypercholesterolemia is a common disease with an almost tenfold increase in cardiovascular risk, and this risk can be reduced by proper treatment. In the guidelines, the patients with familial hypercholesterolemia are subdivided into two groups, one with very high risk and one with high risk. In the very high risk group of patients, we include FH with cardiovascular disease and another major risk factor. Within the high risk group, patients with FH without other major risk factors are all included. So, recommendations for the detection first. FH should be considered in many clinical situations, and especially then in patients with cardiovascular disease at age below 55 for men and below 60 for women, in people with relatives with cardiovascular disease at young age, in people with xanthoma, and in people with severely elevated LDL cholesterol, such as LDL level above 5 millimoles per liter, or in children above 4 millimoles per liter. It is recommended that FH should be diagnosed using clinical criteria and confirmed when available with DNA analysis. Once the index case is diagnosed, family cascade screening is recommended. As we discussed earlier, the patients are divided into risk groups, with one group with very high risk and one group with high risk. For FH patients with cardiovascular disease, they are at very high risk. The goal for treatment is to achieve at least 50% reduction from baseline and an LDL cholesterol below 1.4. If goals cannot be achieved, a drug combination is recommended. In primary prevention for individuals with FH at very high risk, an LDL reduction of a similar level should be achieved with a reduction of at least 50% from the baseline and a goal of less than 1.4 millimoles per liter. This is, however, a lower degree of recommendation of class 2A. Treatment with PCSK9 inhibitors is recommended in very high-risk FH patients if the treatment goal is not achieved on maximum tolerated statin dose plus ezetimibe. We also give guidelines on children. In children, the testing for FH is recommended at an age of already 5 years, or earlier is homozygous FH is suspected. Children with FH should be educated to adopt a proper diet and treatment with a statin from 8 to 10 years, and the goals for treatment should be less than 3.5 millimoles per liter at 10 years of age or above. We then go to diabetes and the metabolic syndrome. As with familial hypercholesterolemia, we subdivide patients with diabetes into very high-risk patients and high-risk patients. Very high-risk patients are patients with target organ damage, if they have more than 3 risk factors, and also patients with early onset of type 1 diabetes of long duration. High-risk patients are diabetes patients without target organ damage and a diabetes duration of more than 10 years, or if they have other additional risk factors. In patients with type 2 diabetes at very high risk, an LDL reduction of at least 50% from baseline should be achieved, and also to reach a target of 1.4 millimoles per liter. In patients with type 2 diabetes at high risk, an LDL reduction of at least 50% from baseline and an LDL goal of 1.8 millimoles per liter is recommended. And of course, statins are recommended as the first drug of choice to patients with diabetes who are at high or very high risk. Intensification of statin treatment should be considered before the introduction of combination therapy. If goals is not reached, statin combination with ezetimibe should be considered. The dyslipidemia in metabolic syndrome and in diabetes represent a cluster of lipid lipoprotein abnormalities, including elevation of both fasting and postprandial triglycerides, ApoB, and small dense LDL and low HDL. The current guidelines, the triglyceride-rich lipoproteins and their remnants are focused more than in earlier studies, and non-HDL as a target and a risk indicator is emphasized. Non-HDL and ApoB are good markers for these lipoproteins, and it's recommended that non-HDL or ApoB should be secondary targets. That is a goal that should be considered when LDL cholesterol goal is reached. This is especially important in patients with diabetes that often have elevated lipoproteins in this class of lipoproteins. For high risk, the desirable level of non-HDL is 2.6 millimoles per liter, and for ApoB 80 milligrams per deciliter. And for very high risk, the corresponding levels are 1.8 millimoles per liter and 55 milligrams per deciliter for ApoB. In conclusion, the guidelines recommend a very active treatment of dyslipidemia in patients with FH or diabetes. All are at high or very high risk for cardiovascular disease. Goals have been changed based on new evidence from clinical trials. Thank you for listening, and the guidelines are published in European Heart Journal and in Atherosclerosis.